Okay. Hello, everyone. My name is Vadim Koshkin. I'm an assistant professor at the University of California, San Francisco, and a genitourinary medical oncologist. And I am happy today to present on this topic, which is immunotherapy for bladder cancer, as part of the Urology COVID lecture series. This is, of course, a very, very important topic and one that I'm very interested in. So I hope that this will be useful. To start out, here are my disclosures. And starting out with the outline of the lecture, in discussing the role of immunotherapy in bladder cancer, I will start out by discussing the current treatment landscape in metastatic bladder or urothelial cancer. I will then go on to discuss immune checkpoint inhibitors specifically in the metastatic space. So starting maybe not initially from the very beginning, but from a space that is most familiar to the medical oncologist, since I am one. And then I will sort of cycle back to the use of immunotherapy and immune checkpoint inhibitors in other bladder cancer treatment settings, specifically in non-muscle invasive bladder cancer, where checkpoint inhibitor is also approved, and then also in the perioperative space, clinical trials for muscle invasive disease, and also adjuvant therapy trials. Finally, at the end, I will discuss the side effects and tolerability of immune checkpoint inhibitor treatment, and I will wrap up with the summary of current immune checkpoint inhibitor landscape in bladder cancer and some of the future directions of this very important space. To start out, it's useful to just put up sort of the big picture slide of the disease and treatment settings in bladder and urothelial cancer. Of course, most patients are diagnosed with non-muscle invasive disease and start out there under the care of the urologist. This is limited to, of course, TA or T1 disease, that I'm sure most of the audience would know, typically is managed by urology with TRBTs and intravesical, I should say, treatments like BCG. But increasingly, medical oncologists are becoming involved in this space as well, now with the approval of pembrolizumab in this disease and treatment space, which I will discuss a bit more later on. Additionally, it should be mentioned that BCG itself is, of course, a form of immunotherapy. I won't really discuss it as such as part of this lecture, focusing really mostly on immune checkpoint inhibitors. However, it should be kept in mind that, of course, immunotherapy, or a form of immunotherapy, which is BCG, has been a part of bladder cancer treatment for several decades now. It's important to not forget that, because that is what really inspired and led to the development of further or other immunotherapy treatments in bladder cancer. Well, as I mentioned, most patients are diagnosed with non-muscle invasive disease. Most are treated in this space. Some still end up progressing to muscle invasive disease or are diagnosed at that stage. At this point, bladder cancer is still organ confined, but invades the muscle wall of the bladder, which makes it essentially a systemic disease, which should be treated systemically. And this is a space of vital collaboration between medical oncology and urology, also with radiation oncology, with chemoradiation or trimodality approach being an important part of the treatment here as well. The gold standard of care, though, and what most patients get for muscle invasive bladder cancer is cystectomy and pelvic lymph node dissection, which of course is preceded by neoadjuvant cisplatin-based chemotherapy for those patients who are eligible. Now, increasingly, immunotherapy regimens are being attempted in this space as well as part of the clinical trials, particularly focusing on patients who are cisplatin ineligible. Patients with high risk at the time of cystectomy are eligible for adjuvant treatment and often undergo this as well. and that is becoming an important space for checkpoint inhibitors also. But then ultimately, patients who progress to metastatic disease, so really disease that is no longer organ confined, but has spread to at least the lymph nodes and possibly beyond, those are the patients where most of the immune checkpoint inhibitor treatment is really indicated. Now, the majority of patients diagnosed with bladder cancer fortunately do not progress to this stage, and certainly only a small minority are diagnosed at this stage. But of course, this is a very important space where the disease is very aggressive and where the treatment intensity needs to match the aggressiveness of the disease. And that's, of course, the space where medical oncologists are typically involved. Now, here, outlined here, is the current treatment landscape of patients with advanced bladder cancer. Again, broadly speaking, we divide patients into those who are eligible to receive cisplatin-based chemotherapy, those who are ineligible for cisplatin but eligible for carboplatin, and patients who are ineligible for any platinum-based chemotherapy at all up front. Those are usually the older and more frail patients. The distinction between cisplatin eligible and cisplatin ineligible usually is made based on renal function cutoff. That's what makes most patients cisplatin ineligible. However, other criteria, the Gaussian criteria, are used as well. And of course, that includes grade 2 or greater neuropathy, grade 2 or greater hearing loss, significant heart failure, or performance status of 2 or worse. That also makes patients cisplatin ineligible. Patients who are eligible for either cisplatin or carboplatin receive platinum-based chemotherapy as a standard of care. Usually, this means a combination of in the metastatic setting of gemcitabine and cisplatin, given for a total of 4 to 6 cycles. Sometimes other regimens, such as dose dense MDAC, is given as well. Now, patients who have a response or at least stable disease, so some clinical benefit to platinum-based chemotherapy, now should receive maintenance, or I should say switch maintenance immunotherapy with avelumab. This is based on the results of a recent practice-changing clinical trial, which we'll go over in a bit. However, other patients who progress despite chemotherapy treatment, so for instance, progress during chemotherapy or shortly thereafter, also should receive immunotherapy treatment. There are 5 different, actually, immune checkpoint inhibitors that are approved in the platinum refractory setting. The only one with level 1 evidence of a randomized phase 3 trial, which we'll cover briefly as well, is pembrolizumab or Keytruda. Additionally, selected patients who are ineligible for cisplatin, but basically carboplatin eligible, but who have a high PD-L1 status, are eligible to receive checkpoint inhibitor treatment as well, with either pembrolizumab or atezolizumab approved, again, for PD-L1 high patients in this situation. And finally, of course, patients who are altogether ineligible for platinum-based therapy, as long as they are still eligible to receive treatment, period, and don't have specific contraindications to immune checkpoint inhibitor treatment, are eligible to receive either pembrolizumab or atezolizumab here as well. And this essentially just highlights that really at this point, where we stand today in early 2021, checkpoint inhibitors are really one of the cornerstones of treatment in metastatic bladder cancer. Basically, most patients in the second line, often in the first line, will see checkpoint inhibitor, most patients with advanced bladder cancer. And that is a significant change to even relative to about 5 years ago, of course. I should also highlight this arrow at the bottom of the slide, just showing that basically treatment should be, or I should say clinical trials should be considered at all points of treatment of metastatic disease as well. And that's something we will go over a bit more later on as well. Additionally, an important addition, I should say, is that For molecularly selected patients, as patients with FGFR3 alterations, that is FGFR3 mutations or fusions, those patients are eligible to receive erdafitinib in a platinum refractory setting. Erdafitinib is an oral targeted agent specifically available for this patient population, which represents about 15 to 20% of metastatic bladder cancer patients and is somewhat enriched in patients with upper tract disease, where it can be up to 40%. This table here just highlights the different clinical trials and supporting the use of immune checkpoint inhibitors in a platinum refractory setting, which I had just gone over. As I mentioned, 5 different agents are approved. These are the drugs listed here: atezolizumab, pembrolizumab, nivolumab, durvalumab, avelumab. I listed atezolizumab first because it was the first immune checkpoint inhibitor approved in advanced bladder cancer, or I should say advanced or metastatic disease. This was in May of 2016, so really less than 5 years ago at this point, almost coming up on 5 years. I listed here first, however, the only drug with a positive phase 3 trial, as I mentioned, is pembrolizumab. This was a phase 3 trial comparing pembrolizumab to standard or I should say second-line chemotherapy in patients who had progressed on prior platinum therapy. For pembrolizumab, this clinical trial was positive, as I will go over in a bit. A similarly designed clinical trial, phase 3 clinical trial for atezolizumab actually was a negative trial. And this is after this drug was initially approved based on results of a phase 2 trial, which showed promising outcomes relative to historical data. 3 other agents that are approved, as I mentioned, are nivolumab, durvalumab, and avelumab. They aren't used as frequently in this platinum refractory space, but do have data to support it and an FDA approval indicating that they can be used. Overall, just comparing across these agents across the board, there is some difference in dosing frequency, where atezolizumab and pembro can be given every 3 weeks, whereas the others, at least in clinical trials, were given every 2 weeks. However, nowadays, nivolumab can often be given as every 4-week regimen. Pembrolizumab actually is now available as an every 6-week regimen. It can be dosed less frequently if needed as well, which actually has become more relevant during the current COVID pandemic, or certainly earlier in 2020 when both patients were more reluctant to come in, and of course we as oncologists were also at least at one point more reluctant, I think, to have patients come in as well. Looking at objective response rates across the board, these really ranged anywhere from about 15, a little bit less for atezolizumab, but generally between 15 and 20% of patients respond. This is response according to RECIST criteria. Generally speaking, about another, I would say 20 to 30% of patients have stable disease, at least initially, as best response, meaning that I would say, and what I quote to patients is about 50% of patients or so have some clinical benefit to second-line checkpoint inhibitor therapy for bladder cancer patients who previously had progressed on a platinum-based regimen. These responses are somewhat enriched among patients whose tumors have PD-L1 expression. However, responses are also seen in patients whose tumors do not have PD-L1 expression. So in this treatment setting, we don't make a decision based on PD-L1 status. Overall, the median overall survival was somewhere in the, I would say, 8 to 10 month range in these trials. This durvalumab trial was a bit of an outlier. Again, the phase 1, I should say level 1 data based on a phase 3 trial is only available for pembrolizumab, and in that trial, median overall survival of patients treated with pembrolizumab was just over 10 months. Treatment-related adverse events across the board are also somewhere usually in the 15 to 20% range, potentially a bit less for durvalumab and avelumab based on these trials. Now, specifically, I want to highlight again this phase 3 study of pembrolizumab that led to its approval in this treatment space. So this was a Keynote 45 trial. So pembrolizumab in platinum refractory bladder cancer that basically randomized patients with platinum refractory metastatic urothelial carcinoma to receive either pembrolizumab or investigator's choice of chemotherapy, which was paclitaxel, docetaxel, or in Europe, influtamine available as well. Primary endpoint was overall survival, and pembrolizumab was favored over chemotherapy with initial hazard ratio of 0.73, which was statistically significant. This data was initially presented at ASCO meeting 2017. Data was updated a couple of years later with basically a final 2-year update showing that at the 2-year mark, a number of patients actually were still on treatment with pembrolizumab, whereas all patients on chemotherapy had progressed by then. And the overall survival at 2 years was about double with pembrolizumab relative to investigator's choice chemotherapy, and about a quarter, or a little over a quarter, 27% of patients treated with pembrolizumab were still alive at that point. So it does appear there is a significant tail to this curve here, which is important to note and an important thing to quote to patients. Now, in the front line, immune checkpoint inhibitors are also approved, at least 2 of them, that is atezolizumab and pembrolizumab. Again, these are patients who are ineligible for cisplatin, but eligible to receive treatment and potentially eligible to receive carboplatin. There were 2 phase 2 trials done, one for each drug, and the details of these trials are basically highlighted here. The pembrolizumab trial was a bit, well, actually significantly larger. It was twice as big, including a total of 370 patients. This was a single-arm trial, so there's no comparator arm. So the comparison was really, again, to what can be expected with standard of care chemotherapy in this space. Objective response rate was 23% for atezolizumab, about almost 29% for pembrolizumab, so a bit higher than in the platinum refractory setting, as you would expect. These are treatment-naive patients. A bit lower, though, than similar data compared, a bit lower than the data in this patient population treated with carboplatin, where responses of somewhere maybe 35 to 40% can be expected. However, this therapy is generally better tolerated than carboplatin. Also, not all of these patients were carboplatin eligible. That's important to note. Furthermore, it's important to note that among patients with high PD-L1 expression, particularly in the pembrolizumab trial, the responses were much higher. So patients with a combined positive PD-L1 score of more than 10%, which is what's considered positive cutoff for the companion diagnostic test for pembrolizumab, their responses were 47%, so significantly higher than just a 29% overall response for the overall population, I should say. Median overall survival was about a year for these patients. Again, the grade 3 or 4 treatment-related adverse events were what you would expect. So again, somewhere in the 15 to 20% range here. Now, moving on to switch maintenance immune checkpoint inhibitor therapy in metastatic urothelial cancer. This was studied in the Javelin Bladder 100 trial. This trial included a different patient population. So these were patients who were treated so patients with metastatic urothelial cancer who were treated in the front line with 4 to 6 cycles of platinum-based chemotherapy. So again, either cisplatin gemcitabine or carboplatin gemcitabine. They received somewhere between 4 and 6 cycles and had a clinical benefit to this treatment, so had response or stable disease. These patients were then randomized 1-to-1 to receive standard of care at the time, which is best supportive care alone, or avelumab treatment every 2 weeks with best supportive care. The primary endpoint was overall survival, and the trial met this primary endpoint, showing a significant overall survival benefit of avelumab with best supportive care over best supportive care alone. And this benefit was by more than 7 months, which is really the largest overall survival benefit seen in any metastatic bladder cancer trial to date. Hazard ratio was 0.69, so this is a statistically significant result. One of the criticisms of this trial was that a lot of the patients in the best supportive care arm were not able to receive subsequent immunotherapy. This is due to many of these patients enrolling in Europe, where essentially because there wasn't a crossover in this trial, they were not able to receive it as standard of care. Despite this criticism, this does remain a very important trial, because although it did not specifically look at this question of early immunotherapy versus late immunotherapy, it looked at the question of giving immunotherapy versus not giving immunotherapy immediately after deriving clinical benefit from platinum-based chemotherapy. It's clear that there is benefit to avelumab in this space. It remains a question whether this is a class-specific benefit or the drug-specific benefit. So could you use another checkpoint inhibitor, so one that you would dose less frequently, for instance, in this space? I would say there remains an open question. There was a similar pembrolizumab trial in this space that showed progression-free survival advantage, but not an overall survival advantage. However, it was a much smaller trial, so potentially was underpowered to detect that difference. Be that as it may, this trial established avelumab as the standard of care switch maintenance therapy for patients who receive platinum-based chemotherapy for metastatic urothelial cancer in the front line, and then should receive avelumab if they have stable disease or response to this treatment. And this is now the new standard of care. So this again, this data fills out, again, this slide that I showed earlier, showing, again, immune checkpoint inhibitors as one of the cornerstones of treatment for metastatic bladder cancer at this point. There are several studies supporting the use of immune checkpoint inhibitors for patients whose tumors are refractory or progress on platinum-based treatment. Again, the drug we use most commonly in this space at this point is pembrolizumab, which is the only drug of the 5 checkpoint inhibitors approved with phase 3 data. For patients who do derive benefit from treatment, so have stable disease or response, switch maintenance avelumab should be used. Patients who do not get platinum-based chemotherapy in the front line are eligible to get either pembrolizumab or atezolizumab, again, based on also prospective data from non-randomized phase 2 trials showing pretty robust activity with either drug in this space. And again, as I mentioned earlier, clinical trials really should be considered across the spectrum of treatment of metastatic cancer. And with that in mind, I highlight here that really bladder cancer treatment in recent years has really been a very dynamic and rapidly evolving space. This lists not even all, but some of the more important recent advanced registration trials or registration trials in advanced urothelial cancer. Many of these trials have completed enrollment and read out, because here we are now in the first quarter of 2021. And we will go over a few of these results now. Importantly, in the frontline treatment space of metastatic urothelial cancer, several trials have looked at alternate regimens or alternate combination treatments to attempt to supplant the use of platinum-based chemotherapy as the main approach. These main 5 trials are highlighted here. Generally speaking, these trials all had a standard of care chemotherapy arm. This is cisplatin or carboplatin with gemcitabine across the board. And they compared this standard of care arm to combination of chemotherapy with immunotherapy, immunotherapy combinations, or single agent immunotherapy. I will go into somewhat greater detail for some of these trials. So Keynote 361 was the pembrolizumab trial in this space. So it randomized patients with advanced or metastatic urothelial cancer into one of 3 arms. So the randomization was 1:1:1 to receive either pembro with chemotherapy combination, pembrolizumab alone, or chemotherapy alone. Again, both cisplatin eligible and cisplatin ineligible patients who received carboplatin were enrolled in this trial. The trial was negative. The primary endpoint was overall survival in the intent to treat population, comparing pembrolizumab with chemotherapy, so this first arm, with chemotherapy alone. And though numerically the overall survival for pembro and chemo combination was somewhat more favorable, this difference was not statistically significant and did not meet the predetermined endpoint. Therefore, the trial did not show the immunotherapy chemo combination to be superior to current standard of care of platinum-based chemotherapy. Similarly, the Danube trial was also a negative study. This study randomized patients also to receive standard of care chemotherapy and compared this to not a chemoimmunotherapy combination like the prior trial, but 2 different immunotherapy regimens. One with just a checkpoint inhibitor monotherapy, so durvalumab is an anti-PD-L1 agent, or a combination of durvalumab and tremelimumab. The co-primary endpoint was is shown here was the overall survival comparing durvalumab versus chemotherapy, specifically in the PD-L1 high population, or durvalumab with tremelimumab versus chemotherapy in the intent to treat population. In both cases, the hazard ratio was not that impressive. It was above 0.8 and was not statistically significant. So again, this was a negative trial presented at last year's ESMO conference. Finally, there's the Invigor 130, which was a similarly designed trial of atezolizumab. It also randomized patients into 3 arms, which not all of which I showed here, but basically arm A was atezolizumab with chemotherapy. Arm C was placebo with chemotherapy. Those were the 2 main arms compared. There was another arm B, which was just atezolizumab, so a immunotherapy monotherapy. The progression-free survival was actually the primary endpoint, and that was significant. So it showed a PFS benefit in the intent to treat population of atezolizumab with chemotherapy versus chemotherapy alone, basically chemotherapy with placebo. The overall clinical benefit was slight. It was less than 2 months, but this was statistically significant. However, in the overall survival analysis of the same comparison, this did not meet the predetermined efficacy endpoint. Therefore, this trial did not show an overall survival benefit of adding atezolizumab to platinum-based chemotherapy versus just platinum-based chemotherapy alone or with placebo. So to summarize again, then adding atezolizumab improved progression-free survival, but not overall survival. Thus, although this was a partially positive trial, I should say, it was not a practice-changing trial. And certainly in where we stand today, the frontline treatment of choice remains chemotherapy alone, not combination of chemo and immunotherapy. So with these important frontline immune checkpoint inhibitor trials in metastatic urothelial cancer, we highlighted the first three. Again, the Keynote 361 and Danube, which were negative, Invigor 130, which met one of its primary endpoints, but showed only a progression-free survival benefit, not an overall survival benefit. So overall, I would say largely was also a negative trial. Therefore, in all these trials, the comparison of the important combination arm, these arms here, with standard of care chemotherapy did not show an overall survival benefit. However, there are two other trials, one from the Checkmate series that includes nivolumab and ipi-nivo, and the Nile trial, which is another AstraZeneca trial similar to Danube. This company names their trial after rivers. Here, whereas Danube compared standard of care chemotherapy to different immunotherapy regimens, Nile compared standard of care chemotherapy to combinations of chemo and immunotherapy. This trial, Nile, is yet to read out, as is Checkmate 901. So these are data that we're awaiting pretty anxiously. I should highlight also that some of these trials did show more intriguing data for PD-L1 positive patients, specifically comparing immune checkpoint inhibitors and chemotherapy used in the frontline treatment setting. In the Danube trial, the combination of durvalumab and tremelimumab in comparison with chemotherapy, specifically in the PD-L1 high patient population, did show an overall survival benefit. Again, this was one of the secondary endpoints, but nevertheless was pretty intriguing, suggesting that this specific patient population of PD-L1 high patients may benefit more from this immunotherapy combination than they do from chemotherapy. Similarly, in the Invigor 130 trial, again comparing atezolizumab with chemotherapy, in the same PD-L1 high patient population, shown here in this panel, on the right, there was a trend towards improved overall survival in patients receiving atezolizumab rather than chemotherapy, which did not quite meet statistical significance, but did have an impressive hazard ratio and potentially did not meet the significance due to the numbers being small, as this was a subset analysis. I should also say that a similar comparison in the Keynote 361 trial comparing pembro and chemo in PD-L1 high patients was negative. So there's some intriguing data that maybe a combination of immunotherapy, such as durva and tremi, which is again a PD-L1 drug and the CTLA-4 inhibitor, this combination may be favorable in PD-L1 high population relative to chemotherapy. But again, that is something that's, I would say, not yet practice changing in this patient population, something that should be investigated further. Again, going back to the slide I keep returning to, which is the current landscape for patients with advanced urothelial cancer. Now I've also added some subsequent therapies, so therapies we use even beyond the second line treatment, which typically is an immune checkpoint inhibitor. Here we have a couple of targeted agents available, including enfortumab vedotin, which is available for all comers in a non-selected patient population, and also, as I highlighted earlier, erdafitinib is a drug that's available after progression with platinum-based chemotherapy or after platinum and immune checkpoint inhibitors for selected patient population, those with FGFR 2 or 3 mutations or fusions. These drugs, enfortumab, and also erdafitinib and similar drugs, are increasingly used in the frontline treatment space as well as part of different clinical trial regimens. In particular, the space of interest for many clinical trials are these patients here, patients who are ineligible for cisplatin and have to usually receive carboplatin or can't even get that potentially. The outcomes with carboplatin relative to cisplatin are certainly inferior. In part, that could be because these are just sicker patients. It's obviously hard to compare these two directly. But all in all, this highlights the specific clinical need in this patient population for more effective and also better tolerated regimens. And many of the recent trials have focused specifically on this space, the cisplatin ineligible frontline space. I highlight some of these trials here. An important trial for frontline patients with advanced or metastatic urothelial cancer has been EV-103. EV here stands for the drug I mentioned earlier, enfortumab vedotin, which is a antibody drug conjugate. It's an antibody targeted against Nectin-4, which is expressed in urothelial cancers. It is linked to a chemotherapy agent that when the antibody attaches to the antigen expressed on the urothelial cancer cells, it is internalized into the cell. The link between the antibody and the chemotherapy agent is broken, and releasing a chemotherapy agent that damages cell DNA and destroys the cell. That's how the drug works. It is currently the standard of care in as third-line treatment for advanced bladder cancer, but increasingly potentially is being moved into earlier treatment spaces as well. This trial included various cohorts combining enfortumab with various other treatment combinations. Well, one of the more active combinations that's read out thus far has been combination of EV and pembrolizumab, checkpoint inhibitor, which in the 45 patients treated produced very robust response rates with overall objective response rate of 73%, disease control rate of up to 90%. This success of this cohort led to it being expanded to a larger cohort that is now randomized in this trial and is randomizing patients to receive EV enfortumab monotherapy versus combination of enfortumab and pembrolizumab. Additionally, it informed the design of now a phase 3 trial randomizing patients 1-to-1 to receive, again, the current standard of care chemotherapy in the frontline space or this combination EV and pembrolizumab. I highlight here also a number of other trials available in the frontline space, specifically for cisplatin ineligible patients. Patients with high PD-L1 expression are being investigated or were investigated in a PIVOT-10 trial, which finished accrual. That was a combination of nivolumab and pegylated IL-2, or Nectar-214 drug. There's also a LEAP-11 trial, which is comparing pembro to pembrolizumab. For FGFR3 altered patients here, there are also a number of trials generally combining an FGFR3 inhibitor, such as erdafitinib or similar, with a checkpoint inhibitor. And some of these are larger randomized trials. Overall, the future directions in the treatment of metastatic urothelial cancer are that immune checkpoint inhibitors, which are now pretty established as standard of care roughly in the second line and sometimes in the front line, are increasingly going to be moved in probably earlier in the treatment course of many patients with metastatic disease, potentially in combination with other active agents. Thus far, combinations of immune checkpoint inhibitors and chemotherapy, when studied in prospective clinical trials, have been disappointing, have not outperformed chemotherapy alone. But other combinations may be more successful, such as the enfortumab and pembrolizumab combination. So stay tuned for results of those trials. We need improved biomarkers to select patients most likely to benefit from treatment. PD-L1 expression is a helpful biomarker, but needs a lot of work. It is something we can use sometimes, but I would say is certainly an imperfect biomarker. Will there be others? That remains an active area of research. And increasingly, even going earlier than metastatic disease, immune checkpoint inhibitors may be used in those treatment spaces as well. And that will be the focus of some of the remainder of my talk. Going all the way back to the beginning now, because as I said, we've gone somewhat in reverse, starting with metastatic disease here. For non-muscle invasive disease, pembrolizumab or Keytruda is actually an FDA-approved standard of care agent now for BCG refractory disease. This is based on the results of the Keynote 57 trial, which is a phase 2 study enrolling patients who are BCG refractory, for whom the standard of care would be radical cystectomy and who were either unfit for or declined radical cystectomy. The trial had 2 cohorts. Cohort A included patients with carcinoma in situ, with or without papillary disease, and cohort B, which did not include patients with carcinoma in situ. The results of cohort A were reported now about a year and a half ago, at the end of 2019. Again, these patients were treated with pembrolizumab for the duration of a year, and were regularly assessed with cystoscopies. Complete responses noted at 3 months were about 40% of patients had a complete response. And most responses were durable. So about 50% of the patients maintained their response at 9 to 12 months post the initial CR. And based on these promising data, the pembrolizumab was approved as a systemic therapy for patients with BCG refractory, non-muscle invasive bladder cancer. This approval came in early 2020, so it's been about a year now that patients have been, eligible patients have been treated with this therapy. In the muscle invasive disease space, so patients who are indicated for surgery and should receive cisplatin-based chemotherapy prior to radical cystectomy, there have also been a number of trials that have looked at immunotherapy regimens in this space. I highlight some of these trials in this table here. As you see here, various drugs have been investigated, including immunotherapy monotherapy with atezolizumab or pembrolizumab in the Abacus and Pure1 trial, respectively, combination immunotherapy, Ipi/Nivo in the Nabucco trial, and also combination of checkpoint inhibitor and chemotherapy. There's the Hoosier Oncology Group trial of pembrolizumab with gemcitabine for cisplatin-eligible patients and pembrolizumab with cisgem for cisplatin-eligible patients. There's also the BLAST study looking at also similar combination of nivo with chemotherapy. Overall, the response rates produced in these trials were comparable to what is seen with standard of care chemotherapy. By response rate specifically, I'm referring to rates of complete pathologic response. So at the time of surgery, pathologic stage of T0, N0. This was seen in anywhere from low 30s to high 40s in these trials. As a reference for standard of care cisplatin-based chemotherapy, pathologic complete response rates in clinical trials are generally somewhere in the 30 to 40% range. The pivotal trial that established this as a standard of care had it somewhere in the high 30s. The downstaging rates, that is not achieving complete pathologic response, but downstaging to lower than muscle invasive disease, so basically less than or equal to T1 and 0. In these trials, that was seen anywhere from about 40 to above 60%, so also quite impressive. These are all single-arm, basically phase 2 trials. So the data is preliminary. There are ongoing randomized phase 3 trials that potentially may impact standard of care in this space. Again, particularly for patients with who are cisplatin ineligible and for whom there is currently no approved or available systemic therapy here. Finally, I will also cover immune checkpoint inhibitors as having a role in adjuvant therapy in bladder cancer. 3 large phase 3 trials have enrolled patients up to this point, and 2 of them have already read out. This was the Invigor 10 study with adjuvant atezolizumab versus observation, and checkmate 274, which is adjuvant nivolumab in comparison with placebo. The ambassador trial of adjuvant pembrolizumab versus observation is still accruing. Invigor 10, again, randomized patients with high-risk disease at the time of cystectomy, defined here to receive either atezolizumab or observation, so not a placebo-controlled trial. The primary endpoint was disease-free survival with a key secondary endpoint of overall survival. This was a pretty negative trial. The curves are basically right on top of each other. The disease-free survival hazard ratio was 0.89, was not statistically significant. The interim overall survival analysis was also not significant. It did not show a benefit of atezolizumab. Patients with high PD-L1 status also did not have more of a benefit. In fact, had a less favorable hazard ratio in this trial. So this was a pretty negative trial, not showing a benefit of atezolizumab in this space. In contrast, the checkmate 274 study was similarly designed and looked at nivolumab versus placebo. So that was actually, there was a major difference in that the previous trial was in comparison with observation rather than placebo-controlled. But the patient population was similar, so patients with high-risk disease at the time of radical cystectomy. So it was, if they had prior treatment, T2 was allowed. If they did not have prior chemotherapy treatment, then it had to be T3 or T4. In either case, no positive patients were included. The checkmate 274 study was just presented literally within the last 2 weeks at the ASCO GU meeting, and did meet its primary endpoint of disease-free survival. It showed a benefit of nivolumab versus placebo with a pretty robust hazard ratio of 0.7. A lot of this benefit was driven by PD-L1 positive patients, where hazard ratio was much more impressive, 0.53. This is, again, brand new data, so has not yet led to any changes in regulatory approval, and potentially might, although again, that remains to be seen. As of right now, these are some of the approved indications of checkpoint inhibitors in bladder cancer. As I mentioned, in non-muscle invasive disease, pembrolizumab is approved for patients who are BCG refractory. A number of trials are ongoing in muscle invasive bladder cancer in this space, but no agents are yet approved. Based on the positive results from the Checkmate 274 study, potentially nivolumab will be approved, but that is not the case yet. So no adjuvant therapy, no adjuvant immunotherapy is approved as of right now. And really, most of the use for checkpoint inhibitors in the treatment of bladder cancer remains for metastatic or locally advanced disease, so more advanced disease, where, as I mentioned, 5 different agents are approved, but pembrolizumab is really the workhorse there. Finally, before wrapping up, I'll just mention a few things about tolerability of immune checkpoint inhibitor treatment. Of course, immune checkpoint inhibitors can have a variety of systemic side effects. It is a robust systemic therapy that can affect really any organ in the body. This schematic here just shows some of the examples. The main things I discuss with patients when discussing checkpoint inhibitor treatment are severe side effects such as colitis, pneumonitis, and endocrinopathies. Other rare things can occur as well, such as, for instance, nephritis and others, including nervous system side effects listed here. Most patients this does not happen to. Most patients actually tolerate these treatments quite well. As I mentioned in earlier slides, the grade 3 to 4 adverse events occur in only somewhere between 15 and 20% of patients, which is not an insignificant number, but not the majority of patients. And I highlight this to patients, but while still highlighting the importance of bringing any new symptoms to the attention of their treating physician, because the key here is always to monitor closely and intervene early. The side effects are really managed based on, well, the specific side effect, but generally speaking, something like a grade 1 adverse event, you can continue immunotherapy for. For grade 2, you usually delay it and treat the responsible condition. For grade 3 or 4 is where you would really consider and probably end up stopping immunotherapy. And then based on the specific side effect and how quickly it resolves, you can consider re-challenging later. But that really is a broader discussion. So to summarize, again, as I mentioned earlier, immune checkpoint inhibitors really have become one of the cornerstones of treatment for advanced or metastatic urothelial cancer. They are increasingly moving into earlier treatment spaces as well. Now approved for BCG refractory non-muscle invasive bladder cancer, that's pembrolizumab. They have a potential future role in the perioperative space, or in the adjuvant space, and in the adjuvant space also, where for high-risk patients at the time of cystectomy, there is now, as of just 2 weeks ago, there's a trial that has shown a disease-free survival benefit for nivolumab. Overall, immune checkpoint inhibitors are well tolerated, but they do require careful monitoring of potential side effects and the management of those side effects if they happen. And despite our overall excitement about immune checkpoint inhibitors and their role in advanced bladder cancer, much work remains to be done. We still could do a much better job of identifying patients most likely to respond, and that means basically identifying better biomarkers of response. And this, along with finding more effective combination therapies potentially, can also produce more durable responses and responses in a greater percentage of patients. And that is also an active area of investigation. It's something that, going forward in the next, let's say, 5 to 10 years, hopefully will make significant inroads and improvement in. This concludes my talk, and I thank you again for your attention. And of course, welcome any questions should you have any. Again, this is a topic that I feel is very important, and certainly very, very important to my research and what I do and to many patients that I treat. So certainly welcome any questions on the matter. And also just as a quick reminder to fill out the survey about today's lecture. Thank you very much for your attention, and hope to meet some of you in the future.